Today, I'm joined by Dr. Lara Barbir, and we're going to be talking about nightmares, sleep, and trauma. Dr. Barbir is a Southern California-based clinical psychologist and supervisor, serving a diverse range of adults in private practice. While she's well-versed in applying a myriad of evidence-based treatments, Dr. Barbir is particularly passionate about using EMDR and interpersonal psychotherapy approaches with higher functioning adults struggling with depression, complex trauma, anxiety, insomnia, and chronic pain. She also has received specialty training in acceptance and commitment therapy, CPT, cognitive processing therapy, written exposure therapy, cognitive behavioral therapy for insomnia and for chronic pain and depression, along with interpersonal psychotherapy for reproductive mental health and motivational interviewing. So let's jump into a really fascinating conversation today with Dr. Lara. All right, welcome. So I'm delighted to speak today with Dr. Lara Barbir about the treatment of nightmares. And before we jump in, just a quick introduction. I'm Dr. Nishi Bhopal. I'm a physician specializing in integrative psychiatry and sleep medicine. And this channel is all about teaching healthcare practitioners about integrative sleep medicine so that you can help improve your patient's quality of life through the power of restorative sleep. So if information like this is helpful for you, please go ahead and subscribe to this channel. Doing so is going to help this information get out to more healthcare practitioners. So let's jump in. Thank you, Dr. Lara, for joining me today. I'm really excited to talk to you about nightmares.
Yes, thank you for having me. I'm really looking forward to chatting with you and talking about the things I'm really passionate about.
Great. Yeah. And, we sort of connected online and we started chatting, and we both have this passion for helping our patients sleep because it really is so fundamental to their mental health and their physical health. Could you share a bit about your background and the work that you do with your patients?
Yes, absolutely. So I'm in the private practice arena now since this year, and I just recently left the VA hospital setting after about 6.5 years, and I was drawn to the VA setting for multiple reasons. One, of course, being there's a very large prevalence of trauma, both in military and war experiences, but also combined with interpersonal and childhood trauma experiences. And on top of that, enjoy working in the integrated care setting where healing is seen as really addressing a patient's problem holistically and being able to collaborate with multiple disciplines to provide that holistic care to be able to target somebody's presenting issues. And I would say also that with the sleep background, I've been drawn to sleep medicine, particularly since learning about and applying CBT or cognitive behavioral therapy for insomnia, and then from there kind of dove in further into the sleep medicine arena and looked at the impact of sleep apnea and how common it is for folks to struggle with treating that with PAP therapy and psychological interventions to help with that. And of course, on top of all of that, just the influence that trauma has on sleep. And of course, the influence that sleep, of course, has on trauma and PTSD symptoms. So really interested in talking about both trauma and sleep. And of course, nightmares occur in both. And happy to be working in private practice now, to have a little bit more flexibility and to be working with a lot of working professionals who are presenting with all sorts of issues.
Well, congratulations on starting your private practice.
Thank you.
I know how much work goes into that. I have a private practice as well, and there's a lot of aspects to take care of. So that's a big step. And it's so interesting what you were just talking about there with regard to trauma, working with veterans, working with sort of a adult professional population as well, and the interconnection between sleep issues, sleep apnea, trauma, and nightmares. Because I think that's what makes the field of sleep so interesting, is that it truly is multidisciplinary. And it affects sleep affects every system in the body, and all of these things interact with each other: physical issues, physiological changes, neurological issues, psychosocial changes, and so forth. So could you share, we'll go into nightmares, but I think a really interesting piece for you to share is maybe the link between trauma and obstructive sleep apnea.
That's such a good question, and we actually don't know like a lot of the association between the two and really what's behind that. But the reason I ended up getting more into sleep apnea is as I was working with folks with insomnia and comorbid trauma, PTSD, depression. I found that a lot, and this was in my work with veterans, but I found that the majority of veterans who have trauma, PTSD, and insomnia also have sleep apnea. And what we thought were some of the classic risk factors for sleep apnea, like being older age, being obese or overweight, having a larger than what's considered average BMI, those classic risk factors were no longer lining up with some of the younger veterans returning from recent war, and so that just fascinated me even more. So just to give you an idea of the numbers, 70% of veterans who have PTSD also have sleep apnea, and I can't speak to some of the like medical perspectives, but there isn't really a good understanding, and obviously this is a gap in the literature and research in the relationship between the two. We just know that there is a very large prevalence. So that has especially informed my clinical work when somebody's coming in and either complaining of insomnia or they have this trauma history, or both of those are going on. I definitely that leads me to further assess for any underlying sleep apnea that might be actually worsening their insomnia and PTSD. And what we actually know is that we should be treating someone's insomnia, whether that's primary insomnia or insomnia due to untreated sleep apnea. We should be addressing that first prior to even considering any sort of trauma focused therapy or other therapy for depression or other mental health issues. Because if we're not going to treat the trauma, if we're not treating their sleep apnea with the PAP therapy being the gold standard, then the patient is not going to benefit as much from the trauma focused therapy, and that's proven in many research studies that show that veterans respond better to PTSD treatment when their sleep apnea is being properly addressed first.
Those are really astounding numbers. And, I think really important for healthcare practitioners to keep in mind if you're working with veterans or people with PTSD, to have a very low threshold to screen for sleep apnea and send them for testing and get that treated. Because as you said, the work that you're doing with them on trauma or even improving their sleep, it's not going to work as well if they have untreated sleep apnea.
Absolutely. Yeah, and I think one of the interesting things that and where nightmares actually come into play are that if somebody is presenting with a concern of nightmares, what I definitely want to assess for is, of course, like what's causing it. Is it related to PTSD, or is it possibly related to them having sleep apnea that has not yet been detected or diagnosed and therefore isn't being treated? Because we also know that nightmares can be treated if we treat somebody's sleep apnea that has not yet been diagnosed.
Absolutely. And so that goes back to doing a thorough assessment with your patients, right? And so today we're focusing on nightmares. And when it comes to treating nightmares, the first step is to assess the underlying causes. And so we'll talk a little bit about that today. Some of those causes include things like sleep disordered breathing and sleep apnea. So before we go into all of that, let's maybe just start with understanding what are nightmares and what is the link between nightmares and trauma.
Yeah. very important question. And I would say that nightmares commonly occur as a symptom of trauma, but they can also be caused or exacerbated by untreated sleep apnea, as I just mentioned. They can be various other causes, like I'm thinking about withdrawal from certain substances, like cannabis, especially, but even certain prescription drugs, which I'm sure you can speak to more so than I can. But SSRIs, for instance. In order to be diagnosed with the nightmare disorder, I think that requires at least 3 times a week somebody waking up and being having distress about certain dreams. And I would mention that nightmares can occur in any stage of sleep, but they're most likely to occur during the rapid eye movement or REM stage of sleep, which is the sleep that where we're most likely to be recalling vivid dreams, and that we tend to get more REM sleep at the towards the end of the sleep period. So as we're the second half of the night as we're waking up. And yeah, they cause clinically significant distress to the person, and they are usually those that are actually recalled. And so this is differentiated from another term, which is called night terrors. And so often the two are confused. So I think just the important distinction are that nightmares are vividly recalled by the person who is suffering from them, and they're occurring few nights a week at least in order to meet criteria for the nightmare disorder in our DSM. Whereas night terrors are typically not recalled by the patient or the person who is suffering from them, and usually only pointed out because that person has a bed partner who's noticing that they're waking up. And night terrors typically tend to happen outside of the REM period of sleep and happen in the non-REM stages, which helps understand why the person suffering from them does not necessarily remember the content of them.
So that's a really helpful distinction. And for anyone who's watching, I have a 2-part series on nightmares going into the details of the symptoms and features to look out for. So if you want to go in depth into that more, you can check out my 2-part video series on that. But so I think that's really helpful to know that nightmares happen usually more during REM sleep, whereas night terrors are usually a non-REM sleep sort of phenomena. So a couple of questions then for healthcare practitioners to ask their patients if they're distinguishing between nightmares versus night terrors would be the timing of when these are happening, and then the recall. Is that correct?
Correct. Yes. So when a patient is complaining of night terrors, it just might be helpful to get a better understanding of what they think a night terror might be, as if they're actually recalling these night terrors themselves. Then it may actually be a misuse of the term, and they may actually be experiencing nightmares, which are these intense, typically a recurring theme to the dream, if not the content is recurring itself, not necessarily. On the note, though, that I think is important to detect, just from my anecdotal experience with folks with untreated sleep apnea who complain of nightmares, is the content of the and the theme underlying their dream is typically that they are there's something involving death, their own death, and then they end up waking up. And so I think something that I typically like to ask is if they're waking up like having any sort of gasping or snorting or choking events, or if that's something that if they have a bed partner, their bed partner is observing, because that can help you delineate between nightmares that are due to sleep apnea versus possibly due to something else, with the something else normally in my mind being related to unaddressed and unresolved trauma, which the patient usually can have a good sense of if they have a trauma history, and the dream content is likely related to that trauma, or in at least theme wise has some sort of relationship.
Great. That's really helpful. And just, yeah, like you said, inquiring about the content of the dream. Are they dreaming of suffocating or is dreaming of their death in some way? Sometimes I can give you clues as to what else might be going on. Do you typically then, so if you're working with someone who has nightmares, when would you refer them for a sleep study?
Great question. Usually at the outset, I want to know if a patient has been in undergone any sort of sleep study, and I'll ask questions to ask about sleep apnea. So snorting, gasping events, choking events, if their bed partners notice that, any daytime somnolence or daytime sleepiness, other questions to detect possible sleep apnea. The stop bang is a very commonly used screening assessment that doesn't necessarily sufficiently detect risk in the younger population that has sleep apnea, but still can be a useful tool to refer to. So thinking about if somebody snores, especially if they snore loudly, if they're tired during the day, if there are any observed apneas, or if they observe any sort of snorting or gasping or choking events. And then things that get at BMI, their age, gender, as males are more likely to be affected than females. And so I want them to make sure that we're ruling out sleep apnea or any other underlying sleep disorders that could be influencing their nightmares. For instance, periodic limb movement disorder, and those kicking or jerking movements of the legs. If somebody's not getting sufficient sleep because of a sleep disorder, that can lead them to spend more time in the REM period of sleep, where of course they're going to be more likely to actually recall having vivid dreams or nightmares. So right from the outset, I would like usually to try to rule out the influence of possible other sleep disorders and to get a sleep study done initially to rule out that the nightmares aren't caused by sleep apnea or another sleep disorder.
Great. Yeah, I think that's great advice. And again, an important reminder for healthcare practitioners who are seeing patients with nightmares to really consider sleep apnea as a cause. And I'll also just kind of piggyback on what you were saying about the stop bang questionnaire, that it does have its limitations. So it might not detect sleep apnea, like you said, in younger populations or in women as well, because sleep apnea can show up in a much more subtle way in women than it does in men.
Mm-hmm. Yeah. So I appreciate you sharing that. Some of the complaints in women are considered atypical in that they might be complaining more about insomnia, or they might be coming to you complaining more about waking up with morning headaches or just unrefreshing sleep. Whereas some of the other complaints that you might hear from men may be a little bit more of that their bed partners complaining about their snoring, or that they're dozing off easily during the daytime.
Great. So that's super helpful. So let's talk a little bit about treatments. Okay. So let's say you've got a patient, you've done the sleep apnea testing, they don't have sleep disordered breathing, they don't have periodic limb movements or other issues. So it's a primary issue with nightmares. There are medications that can be helpful, but the data on those are actually mixed. Sometimes, with my own patients, sometimes I'll see that medications can be helpful for nightmares, but I see this question come up a lot on physician Facebook groups, especially psychiatry physician Facebook groups, where there's a lot of discussion about how do we help our patients with trauma and nightmares, because medications can only do so much. So there are different kinds of non-pharmacological therapies available, and this is really kind of your expertise. So yeah, maybe you could share a little bit about those, and then we can go into detail about the different options.
Absolutely. So I think the first thing that I want to assess is to try to get to the root of what is actually causing the nightmares, right? Did they seemingly come about just out of the blue, or is there an identifiable event or perhaps series of events that might be influencing that? And usually the patient, if maybe you can ask their perception of why they think they're having the nightmares. Some might pull you directly into an identifiable traumatic event or trauma that has happened to them that might be influencing the present, or that if they don't, that might be something worth asking your patients about. Have you been exposed to or witnessed or learned about that, some sort of traumatic thing happening to somebody close to you that could be influencing this? Because if you can identify that there's actual trauma, then you might actually be looking more at identifying symptoms of post-traumatic stress and then treating the post-traumatic stress. Because if you just go into a nightmare disorder treatment, like the imagery rehearsal therapy is the most common and has mixed reviews. And the reason why is if you go into just treating the nightmares without considering the possibility that it's caused by underlying post-traumatic stress disorder, then what's going to happen is that person is going to end up needing to go into trauma-focused therapy thereafter, because it's going to start bringing up some of this. And so that's why I think it's really important to get the patient's perception of the nightmares, and to make sure that you're ruling out that there isn't a traumatic event. And just in my anecdotal experience, there's typically some sort of trauma that's involved. And so there are a number of both trauma-focused and non-trauma-focused therapies that are effective in treating post-traumatic stress reactions and trauma. As you know, I have a current bias towards EMDR therapy, which I can talk briefly about if that's of interest. If somebody does really, though, have a primary nightmare disorder, which is typically defined, as I mentioned, by at least 3 nights a week, they're having a recurring nightmare that's been ongoing and is causing them significant distress, then something like imagery rehearsal therapy would be indicated. And imagery rehearsal therapy is a very brief evidence-based treatment. Can actually, if the patient is an active participant and participating in the homework assignments in between the sessions, then it can be wrapped up in 6 sessions or less. And so, and what this does is, as the term imagery rehearsal therapy suggests, is it's a type of exposure therapy where you're having the patient actually write out during the daytime while they're conscious and awake their nightmare to get that exposure, and then they're at the end, they're re-scripting the end of that nightmare to be more neutral or even more positive, and you can actually give the patient a sense of agency and control, and allow them to actually choose what the ending is, and to deliberately rehearse that during the daytime for a series of several weeks until, and what this does is it aims to actually help change the content of the dream at the nighttime, and just helping in general. The exposure therapy is the exposure to the fear of the nightmare, which often actually has the unintended effect of influencing their dreams in the evening. This is a type of therapy that's offered in individual, but has also been shown to be effective in group formats as well.
Great. So that's really helpful. So imagery rehearsal therapy, or IRT.
Correct.
So as you were saying, oh, go ahead.
I apologize. That I also wanted to mention that it's also been shown that CBT for insomnia, or CBTI, cognitive behavioral therapy, is what CBT stands for. CBTI for short, has been shown to be effective in reducing nightmares as well, because it helps consolidate somebody's sleep by prioritizing the quality. And if the quality of somebody's sleep is prioritized, then they're going to get back to a more standard sleep pattern. For as those who suffer from insomnia in general are more likely to spend an abnormally higher amount of time in the REM stage of sleep. So that essentially means that because they're spending more time in REM sleep, they are going to be more likely to be dreaming, and the content of that dream might be more negative, especially if you can imagine somebody's chronically sleep deprived and like not in such a great mood as if any of you have had periods of insomnia, you might understand that. So CBTI can be effective in actually reducing nightmares in and of itself by helping consolidate someone's sleep and get back to the what's considered normal, which is about 25% of a person's time during their sleep time should be in that REM stage of sleep.
Great. Okay. So much great information there. I'm just going to fix my lighting here. So no, that's fantastic. So, okay. So you talked about IRT, or imagery rehearsal therapy. So that's a non-trauma focused therapy for nightmares. CBTI, cognitive behavioral therapy for insomnia. Again, a non-trauma focused therapy that can be helpful for nightmares and for insomnia, of course. CBTI is so interesting because it has such a broad range of benefits beyond insomnia. As you were just saying, it helps with nightmares. It also can reduce anxiety and depression. It's safe for a variety of patient populations, from, pregnancy, postpartum, patients who are on multiple, polypharmacy, multiple medications. It has such a broad range, variety of effects. So a couple of questions. So who do you find benefits most from IRT, or imagery rehearsal therapy, just in terms of patients? What types of patients do you think are better suited for that? And then for CBTI, as you said, patients with insomnia would be best suited for that. So could you speak about that? So if people are thinking about, okay, should I send this patient for IRT or CBTI? How do you formulate that?
Oh, yes. That's a great question. And honestly, I think that very few people are going to be routed directly to IRT, because, as I mentioned before, from my anecdotal experience, usually the nightmares are a symptom of something else, whether that be post-traumatic stress disorder or some sort of post-traumatic stress reaction. Maybe they don't meet full criteria per se, but it's still relevant, or could be related to untreated sleep apnea or withdrawal from substances, especially cannabis. If those people you're meeting have used cannabis and have likely developed a dependence to it, and they're weaning off of it or stopping it, they will notice more intense dreams. Also, those who are addicted to nicotine and coming off of nicotine might experience those as well. So if you do end up, though, having somebody who is simple, like has a primary nightmare disorder, and there is absolutely no sort of trauma, and you've ruled out that they have sleep apnea or that there's any sort of substance withdrawal, that would be the patient. And otherwise, it sounds like their sleep is a pretty, if they have a pretty standard routine and for their sleep period, then that would be the patient that you would route directly to IRT. For CBTI, if somebody, I think you, and what my, I guess, style is I typically like to talk with my patients about all of these options and then collaborate with them on a decision of what makes the most sense to them, because the effective treatment is often that you want to think about is the one that the patient is willing to participate in, honestly. And sometimes for folks, CBTI sounds less daunting than a nightmare rescripting sort of treatment like IRT, where they have to actually expose themselves to the nightmares. So sometimes a patient might only be willing to try CBTI. And so I think it's fine if they want to go to CBTI and to try that out, because CBTI, much like IRT, can actually be wrapped up within only a handful of sessions. So I think presenting them with the options of CBTI and IRT, if they have a simple nightmare disorder, and collaborating with them on a decision would be the route that I would take. And then, of course, if it's not a simple nightmare disorder and there is trauma, then you might want to talk with them about the multiple options that they have for trauma or trauma-focused therapies, both which are effective in treating trauma and its many sequelae, including insomnia and nightmares.
Okay, fantastic. So let's talk a little bit about some of the trauma-focused therapies. You mentioned EMDR. Are there other ones that you also would recommend for nightmares? And could you share more about these modalities?
Yes, absolutely. I having been in the VA system for the last 6.5 years, there in the VA there is a bias towards a couple of trauma-focused therapies, which are deemed the gold standard treatments for PTSD. There are two of them, and they are what's called cognitive processing therapy and prolonged exposure therapy. Both of those are actually types of cognitive behavioral therapies. They usually are weekly therapies, and the randomized controlled trials for them show that within 12 weekly sessions, each session being about an hour, where the patient is an active participant, that this is effective in reducing PTSD related nightmares, as well as PTSD symptoms. That we also know, though, that the other trauma focused therapies and many non trauma focused therapies are effective. So I'll briefly go through what those are. Some other trauma focused therapies are written exposure therapy, which is actually a newer therapy that I trained in earlier this year, but it actually involves more of writing, as the term written exposure suggests, where the patient is actually writing in during the session with their clinician about a specific traumatic event that they went through, and then working through in between the sessions, allowing themselves to experience any intrusions, whether that be intrusive thoughts, memories, images, and feelings that come up when doing the trauma work. This similarly happens with cognitive processing therapy and prolonged exposure therapy. Prolonged exposure therapy is a little bit different from written exposure therapy in that instead of doing writing, what the patient is doing is they are talking out loud in major detail, including sensory details as well as details about internally what's happening, as they are essentially reliving a traumatic event that they endured, to help expose them to the fear and to help them habituate and desensitize to the fear of that's being triggered in the present day, when they're reminded of the traumatic event they experienced. So that's what's called an imaginal exposure. And then the second exposure component of prolonged exposure therapy is called in vivo exposure, where a patient is starting to face some of the feared situations that they either endure with intense fear or they avoid altogether because of the triggering impact that that event or activity has in reminding them of a traumatic event. Cognitive processing therapy slightly different in that the idea is that a patient becomes stuck in recovering from their PTSD or trauma related symptoms because their core beliefs about the world were disrupted, and their core beliefs about themselves and other people were disrupted in the face of trauma. So the patient works to help to identify and explore some of the distorted beliefs they developed, and then going through worksheets to help change, to work and challenge some of the distorted thinking patterns to help them become unstuck so that they can successfully recover from their trauma. And then kind of the last one, there is a briefer protocol for prolonged exposure that can be done in a primary care setting. So when I worked in primary care clinics in the VA, I provided the briefer prolonged exposure therapy. So instead of being about 12 sessions like traditional prolonged exposure, it's closer to about 6 sessions that are were 30 to 40-minute appointments instead of 60. And then last but certainly not least, in my opinion, the last trauma-focused therapy is eye movement desensitization reprocessing, or EMDR therapy, which I mentioned earlier. And the theory behind EMDR therapy is that some of the present day triggers that people experience, so the PTSD symptoms, but also depression, anxiety, self-doubt, other sorts of symptoms, are occurring because of memories in our earlier life. So we want to think not just about maybe more recent traumatic events as adults, but even and especially some of the earlier memories in childhood, where we were disturbed, that is influencing some of the present day moment triggers that are being experienced. And so EMDR says that by coming to identifying what some of these earlier experiences are, and working to actually successfully process them, that we can start to get rid of some of those present day triggers and live our lives more fully. Something that I appreciate, and maybe this is why I have more of a bias towards EMDR, at least in the present day, I believe, is that it has more of a somatic component. It feels there's more of an appreciation for the fact that a lot of trauma is endured and experienced non-verbally, and that in order to successfully process a trauma, we not only want to like talk about it or write about it or think about it, but we want to experience it, and experience somatically what we perhaps were not able to process somatically while we were in the face of enduring a traumatic event itself. And so I think that EMDR is unique in that it, from the other trauma-focused therapies, in that it is actually focusing on and emphasizing really that somatic component of experiencing in the moment now, when you're looking back at a traumatic event, what's actually felt, so that a memory can be successfully processed and lead to more adaptive functioning, as well as a greater sense of self efficacy in the patients themselves, when they are able to go through this process and gain a sense of personal strength. So it also ties, and from my view, into post-traumatic growth, which is my primary topic of study during graduate school and part of my dissertation. Last thing I'll say is that non-trauma focused therapies are also effective in treating trauma and PTSD. And as I said before, you really want to consider the patient's preference and what they're really willing to do. Honestly, like, trauma focused therapy is really scary. And I think people have to go through a process of coming to terms with their trauma and really being ready to face it. And many people actually drop out, especially of prolonged exposure therapy, which of course is incredibly difficult because you're required to relive your traumatic experience each time you're going to therapy, as well as on a daily basis in between the sessions. A lot of people really aren't willing to go there, and that's okay. And that's why I think that we should also emphasize that non-trauma focused therapies are effective. For instance, we know that interpersonal psychotherapy is effective in treating trauma, sequelae, and PTSD. And we also know that acceptance and commitment therapy, or ACT, is effective, and then mindfulness-based approaches. So there have been randomized trials for both mindfulness-based stress reduction, or MBSR, as well as mindfulness-based cognitive therapy, or MBCT. All of these, similarly to the gold standard treatments for PTSD, can be successfully completed within about 12 or so sessions. For IPT, or interpersonal therapy, is sometimes a little bit longer than that.
Great, fantastic. So much amazing information in there. And yeah, no, that was really great, really helpful. And I think, for anyone watching this, you might want to rewatch that and pick up on some of the nuances and details that Dr. Lara was sharing. So, I think the kind of the gist of it is that there are lots of different options available for people. And the main thing is to figure out what a patient is willing to engage in, and what feels kind of manageable and sustainable for them. And I think one of the challenges for psychiatrists, healthcare practitioners, primary care physicians working with these patients is finding the resources. So if a patient wants to do IRT, if they're willing to do EMDR or any of these other modalities, I think one of the challenges is finding people to refer them to, like, who can work with them. What tips do you have on connecting patients with these resources?
Great question. I would say oftentimes I like to offer self-help options as a baseline. I think that the ptsd.va.gov website is particularly helpful in talking more about symptoms of trauma and PTSD and what the different treatments are, both pharmacological and the psychotherapy treatment options, which I'll just briefly mention that SSRIs are the first line treatment for trauma and PTSD. And at the same time, we know from research, though, that therapy has for PTSD, psychotherapy has larger effect sizes than SSRIs. And we actually know that EMDR therapy, at least there's a recent randomized trial that shows that EMDR therapy was superior to I believe Prozac was the SSRI in treating PTSD. So that's something to take into consideration and to inform your patients about. They can visit the ptsd.va.gov website. I also think that the book called The Body Keeps the Score by Bessel van der Kolk is an amazing resource that goes into more detail about a lot of the things that I've been talking about and can be a good book to refer to. Of course, I would recommend that patients consult their individual insurance providers if they are interested in therapy and looking at the different options. And normally, they might want to narrow their search to these specific treatments that they're interested in, as well as the specific issues that they'd be interested in working in.
Great. So we'll put all of those resources under the video in the video description as well. And I'll just add, I'm creating a clinical sleep kit for healthcare practitioners that kind of provides them with these resources, where to send patients for CBTI, what different programs are out there and the costs and things like that. So if anyone's interested in learning more about that, you can sign up for the wait list. The link will be under this video as well. But you've shared so much great information, and I think we've already touched on this, but I'd love to kind of put it all together and hear what clinical tips you have for clinicians. Is there anything else that you want to share, or any just kind of pearls of wisdom for healthcare practitioners who are seeing patients with nightmares?
With nightmares, for patients with nightmares, I think just really targeting like good sleep hygiene is maybe like just some of the initial tips that you can offer them. And I think one of the single most important things is just that you're waking up and getting up at the same time each day. As humans, we love to operate on our bodies and brains love operating on routines. So setting that consistent wake up time and getting up at that same time, even if we're not working that day, I think is the point to drive home. So try to keep that consistency. And then thinking about that for other aspects of the routine as well. And for those who may be struggling with some of more of the anxiety that influences can influence the nightmares and their sleep pattern, that they're really setting a nice like winding down routine, which we in CBTI like to call a buffer zone. So just making sure that there's a good transition between the long work day and evening time. So really honing in for those that have anxiety on that bedtime routine, with the goal of doing something that is actually not goal oriented. The purpose is really to relax. So setting aside any kind of planning or prepping for the next day or later parts of the week, and doing things that are relaxing and help wind down both the body and the mind. So thinking about like soothing things that are soothing, like non-caffeinated beverages, hot teas. Again, non-caffeinated is key there. And then things like warm baths, showers, meditation practices, other sorts of ways to relax the body or the mind, drawing on things that people have used in the past. I think those are important things that can really help with having a good night's sleep. And again, routines. So if you're setting that consistent wake up time, that's going to help reset someone's circadian clock and allow that sleep pattern to be more predictable. So that will likely lead to a pretty predictable time at night where they're feeling sleepy and therefore ready to go to sleep. And then the last tip I'll mention, which is really important, is just only using the bed for sleep, with sexual activity being the only exception to that, as our brains take in information over time. And if we use our phones or read or watch TV or do anything in bed besides sleeping, our brain starts to take in that information and be conditioned to be awake in bed at night. And we don't want that to happen. So of course that means if they have a nightmare in the middle of the night, before they're starting to get actual treatment to address what's causing the nightmares, you'll want to recommend that they actually get out of bed, out of the bedroom altogether, if possible, so that they can reorient, kind of work through, and help calm themselves down, and then return to sleep once they're sleepy again, to help make sure to drive home the point that they're only using the bed and the bedroom, if possible, for sleeping.
Well, excellent. Well, thank you so much for sharing all of your expertise, your knowledge, all of these tips. I think this was really helpful, and it's going to be high yield for people who are supporting their patients with sleep. So if people want to learn more about you, if they have patients to refer to you, how can people work with you?
Yes, I'm happy to consult and provide and talk more about this stuff all day, as you might imagine. Thanks for having me here. You can definitely check out my website right now, as I'm working on a practice name. It's larabarbir.weebly.com. Feel free to email me at drlarabarbir@gmail.com with any questions. Again, happy to consult and answer questions at any point. Thanks so much for having me too. I really appreciate it. And for you allowing me to talk about this stuff. Very passionate about.
Yeah, no, it was really my pleasure. I really appreciate you taking the time to be on. And I think there's so much more we could talk about. So maybe we'll find a time to do another video and kind of, talk about different aspects of sleep. But thank you again for being on today. If information like this is helpful for you, please go ahead and subscribe to this channel. Doing so is going to help this information get out to more healthcare practitioners.